Hi, everybody. I'm John O'Neill, and my current position is I'm a civilian consultant in occupational medicine for Navy BUMED. I have an interesting career. I'm actually retired Air Force. I spent 10 years active duty. My last assignment, I was a consultant OCMED to the Occupational Environmental Health Lab at the old School of Aerospace Medicine at Brooks Air Force Base, which has now moved to Wright-Patt. I spent 10 years, some years, 6 years in the Kansas Air National Guard, and retired about 4 years ago as a senior flight surgeon. So I have a background in both in aerospace medicine. I spent 4 years in the active duty Air Force. I was going to get out. Air Force made me an offer I couldn't refuse, which was to pay me to get an MPH and residency in occupational medicine at Harvard. So I did that, and it was a great deal. And I came back as a consultant, got out. I have some corporate experience. I was a medical director for a while for Boeing Rocketdyne that makes the space shuttle engines. And then I also, FACOM is a fellow of the American College of Occupational and Environmental Medicine. Anybody know what an MFA is?
Master's of Fine Art.
You got it, Master's of Fine Art. I took a couple years out from my practice, and I got a Master's of Fine Arts in screenwriting, which has really enriched my life. So, and I still do some writing and stuff. Go ahead, next slide. I will not discuss any use of medicines on this next. So this is really about lifestyle medicine. Many of you have heard the term lifestyle medicine. Anybody heard that? I'm probably preaching to a lot of the choir here and stuff. But it's a term that started about 20 years ago, and there is now American College of Lifestyle Medicine. Their definition is the use of lifestyle interventions in the treatment and management of disease. American College of Preventive Medicine, under which I'm onboarded, their definition is a scientific approach to decreasing risk and illness burdened by utilizing interventions such as nutrition, physical activity, stress reduction, smoking cessation, avoidance of alcohol abuse, and rest. Next. So when we look at chronic diseases, most of the data shows that up to 80% of chronic disease is due to lifestyle choices, which is pretty amazing, including obesity, diabetes, smoking, hypertension, cholesterol level, high cholesterol, stroke, heart attacks, and cancers. Next. So let's look at the difference between what conventional medicine is versus lifestyle medicine. Conventional medicine treats individual risk factors. Lifestyle treats lifestyle causes. Patients are often a passive recipient of care, meaning passive, you take a pill, it's still some active but passive. In lifestyle medicine, the patient is an active partner in the care. They're actually involved with it. The patient not required to make big changes. You may have to take a pill or do something like this, but in lifestyle medicine, the patient is required to make big changes. They're required to make lifestyle changes to look at that. Treatment is often short-term. You have something for gout, you take that, you get over it, you don't mind. But in lifestyle medicine, the treatment is always long-term. Lifestyle medicine is sort of for life. I got to that point. Medication is often the end treatment. Medication may be needed as an adjunct to lifestyle changes. You may need something, but the goal is to really get you off medicines. Emphasis on diagnosis and prescription. The emphasis in lifestyle medicine is on motivation and compliance. Next slide. The goal in conventional is disease management. The goal in lifestyle is disease prevention. Little consideration environment. Lifestyle, you consider your environment where you're living and working, like from the occupational. And I came into this really from the occupational side because healthy workers are more productive. And it really trend in the last 10 years in my field, occupational medicine, is to keep workers healthy and productive. And that's how I got into lifestyle medicine. I've merged into some other stuff and done a lot of lifestyle changes myself. Side effects balanced by benefits. The side effects are the benefits. The side effects you have from lifestyle changes. Referral to other medical specialists. And in lifestyle medicine, you usually refer to other allied professionals, which are going to be someone for sleep, relaxation, dietitian, something like that. The doctor operates independently on a one-to-one basis, whereas in lifestyle medicine, the doctor coordinates with other people. It's expensive for regular medicine. I have a friend who is obese, has prediabetes, and last year he got super excited because of a new medicine that came out that he did a shot subcutaneously and didn't have to do all this the once a month, I think it was. I don't follow that because I don't treat. And he was super excited about it. And I said, how much does this cost? He said, it costs $700, but my insurance pays for it. Well, his food budget for the whole month wasn't even $700. So when you start looking at some of that stuff, it's actually, and even you talk about meats versus other stuff, it's a lot cheaper to buy vegetables. So I'll go into some of that later. Next. So conventional medicine treats symptoms, grossly simplifying this to make a point. And then lifestyle medicine treats the cause. And it's really much better to treat the cause and the symptoms. Next. Disease management, treating cause with symptoms, and disease prevention, treating cause before symptoms develop. Which do you think is cheapest? Absolutely. Next. So we talk about prevention, 3 different types. Primary, it prevents a disease from occurring, i.e. avoiding excess sunlight. We're talking about skin cancers and maybe melanoma. Secondary, disease present, but prevent the symptoms. This would be like checking monthly for your skin lesions, and I still do that. Tertiary treats the symptoms of disease. Prevent further damage, prevent pain, maybe have surgery at that time, removal of moles. I actually, when I was an intern at Wilford Hall years ago, I watched my father go through the last stages of metastatic melanoma. And he had a mole that was on his foot. He thought it was a blood blister. And, you know, I learned more about being a physician that year following my father's progress through metastatic melanoma. But also that got me to the point that when I see a patient, I will look at their body and I will tell them, this looks suspicious, follow up with somebody. So it's something I've done in my own practice. Next. So now at the American Board of Preventive Medicine, and there's 3 subdivisions of it. Those that are, of course, are going to be aware of aerospace medicine. I do occupational medicine, prevention and treatment of illnesses and injuries of workers. And the third part is public health and general preventive medicine. Now, in order to prevent, you need to know what causes something. I give another lecture called Causation Determination. It goes into the medical differences in what exposures cause something. It's a whole other thing. But so it makes sense for the people that are in preventive medicine to understand what the cause is. Does an ER doc care about what the cause of someone's heart attack is when they're trying to keep them alive? That's probably not. They're not going to think about the historical reasons why they got that. Next slide. Prevalence of lifestyle medicine. Prevalence is the number of people with the disease right now. 2/3 of Americans are overweight or obese. Half have abdominal obesity. 1/3 have cardiovascular disease, have coronary heart disease, hypertension, high LDL and low HDL, diabetes, metabolic. And this data is probably 5+ years old, so it's changed. There's been a lot more people having this stuff. Anybody heard of BMI, body mass index? Really interesting. I'm going to talk about just a little bit to give you an understanding about body mass index because it goes into definition of overweight and obesity. BMI is actually weight over height squared. And where it came from back in the 1800s, there was a mathematician from Europe, I forgot what country's from, Belgium, named Adolphe Quetelet. And Quetelet was a mathematician, wanted to figure out, was really interested about the average human, the average man, and came up with calculations and did a thing about weight and height and came up with what's called the Quetelet index. And that was weight over height squared. So jump ahead, it was sort of used as the average man. Jump ahead to the 1970s, and somebody looked at it using the Quetelet index. And insurance companies wanted to try to figure out who was going to live the oldest, actually who's going to die the earliest so they can charge them more money. So what they looked at when they looked at the Quetelet index, which they renamed as body mass index, they found that if your BMI goes above 25, life expectancy starts going down. And they named that obesity level 1. If your BMI is above 30, it goes way down. and that was called obesity level 2. Well, by the end of the 1970s, over half of Americans were classified as obesity level 1 or over 2 as obese. So they changed the definition of obesity level 1 and called it overweight. So now that all of a sudden we had a lot less people that were obese by the definition, does not change the fact that as a population, if your BMI is above 25, life expectancy goes down. Hospital use, medication use goes up. So the reality of it is even though we say overweight, if you look at curves of life expectancy and health, if you're over 25. Now there's a stipulation, as one study shows, for guys that have a little more muscle mass, that curve doesn't start going down until 27. So that makes me feel good because I'm like at the 26th point. I can't get rid of this yet. I'm still working on it. But that gives you a little background. So BMI really has nothing to do with Are You a Gladiator? Pretty much all pro football players are going to be overweight or obese. But also, if you look at the life expectancy, the lowest life expectancy of any working group is linemen in pro football, because they start having heart attacks and dies in their late 30s and 40s. That's a whole other discussion. So that gives you a little bit of understanding about BMI. It has nothing to do with are you in shape, nothing to do with being a gladiator, but everything to do as a population with living a long and healthy life. Does that make sense to you? Next slide. Prevalence of lifestyle-related diseases: 4/5 of American population, poor diet, 3/4 of inadequate physical activity. I'll define that a little more. Lots have secondhand smoke exposure. A lot exceed daily alcohol recommendations. A third get inadequate sleep, which is less than 6 hours a night. Still, 20% of Americans still smoke. That may have gone down a little bit more. A lot binge drink. Only 1 out of 33 people, 33 in the US have a healthy weight, not smoking, physically active, adequate fruits and vegetables per day. That's pretty low. Next, unique role of lifestyle medicine. There's a strict focus on lifestyle behaviors. Success depends upon patient motivation. It's something the patient has to actually start doing it themselves. Applies to every practice and every patient. It's collaborative team model. There's a team of health professionals that help with you. There's a limited number of interventions. Actually, there are thousands of medications, but they're limited interventions in lifestyle medicine. And we would call it a prescriptive lifestyle interventions. And there have been numerous studies that show if a physician or a nurse writes a prescription that says, get 7 hours of sleep every night or exercise 5 times a week, it actually helps work because they're telling them to do something. Or to eat. When I talk to my patients, I can't get anywhere by saying you should be a vegan or vegetarian. No. What I say to them is I recommend you eat more plant and less animal products, because you can wrap your mind around that and they're not going to get all mad. Now, technically, I'm not a vegan, because vegan, you won't kill an animal or anything. I have leather shoes and leather things, so I'm not a vegan, but I do plant-based diet. So there's a lot of stuff in there. But what I found is I recommend you eat more plant and less animal products. And that works from a healthcare perspective. It took me a long time, 3-4 years, to sort of transition my diet over on stuff. As I read more and more of this stuff, and I had more and more friends my age die, I said, I want to be around long healthy. Next slide. So lifestyle medicine interventions proven to help all of these things. It is literally remarkable how healthy you can be if you have a healthy lifestyle. I'm not going to go into each of these, but all of these have evidence-based studies, and pretty much all cancers have some association with lifestyle, particularly with diet. Next. Let's talk a little bit about obesity. We've already talked about obesity. Our clinical definition is BMI over 30. Exercise, diet, calorie restriction, portion reduction, lower energy, whole grains, rich vegetables, get lower glycemic in it. I'm not going to go into a whole bunch of this, but this is what you see when you go to Leach's. And our generation, my generation right now that's aging, I'm older than most of you, will be the first generation in the history of the United States that lives less long than their parents, based on pretty much diet and lifestyle stuff. Smoking's going down, but obesity is going way up. Next, hypertension, high blood pressure, associated with sodium intake, aerobic exercise, BMI less than 25, limit alcohol, less saturated fat, cholesterol. When I talk to people, I talk about hypertension. I put this here because if you have an extra 2 inches of weight around your stomach, of fat, that's at the end of the vascular system.
Oh, did it find a definition?
Siri was trying to.
Thank you, Siri. Thanks for the update. Shows how much is tuned into me doing that stuff. But when I talk to a patient, oftentimes it's an examinee. I'm not entering doctor-patient relationship. I will talk about hypertension. If you have an extra 2 inches of fat around your waist, it's at the very end of the distribution system of blood. And how do you get the blood through this extra 2 inches? Well, your heart has to pump harder to get it there. And the analogy I use is, let's say you're at a football field and you have a sprinkler at a 50-yard line. You're trying to get water and you add 10 more yards of grass at the end zone. How do you get the water there? This one. The blood pressure has to go up. And then I can sort of see little light bulbs go off and say, oh, that makes sense. So the three main things that deal with hypertension in the American population, first is weight. The secondary thing that goes with it is obstructive sleep apnea. I have a whole other lecture I give on that. And the reason that is because at night, when you stop breathing for a bit, your oxygen saturation goes down. So your blood has to pump harder and faster to get less oxygenated blood to your body. So, and that it rolls over into daytime elevated blood pressure also. And then the third thing is the diet. And there's a really high correlation with diet and blood pressure, independent of obesity. They sort of all mix together because if you're obese, you're more likely to have, if you're classically obese, you have like greater than 75% of having some form of obstructive sleep apnea. But for the diet alone will decrease your blood pressure. And I can know that from my own self. I'm the same weight that I was when I was in the Air Force 30 some years ago. A little less muscle, a little more here. But in my mid 60s now, my blood pressure is significantly lower than when I was in my 30s. And this thing that says as you get older, your blood pressure goes up does not happen in people that have good lifestyle changes and good diet. So it's something to think about. You do not have to have your blood pressure go up. But those are the three big factors: weight, obstructive sleep apnea, and diet. Next.
Is there a cautionary tale to powerlifting? I just saw your picture in the bottom.
Oh, yeah. Oh, and I'll go. You ask a question. Here's what happens. So there are multiple cases of people in their late 30s, and 40s, powerlifting, bulking up, and dying of heart attacks and strokes. And the reason is it takes your heart more energy to pump blood through dense muscle than it does through fat tissue. Does that make sense? So do I recommend lifting? Yes, but not for bulk. And even people that lift for strength, you look at people that die young, power lifters, weightlifters. Now, if you're interested, have you seen, there's a video called The Game Changers? Okay, and one of the people that talks there is Arnold Schwarzenegger. And Schwarzenegger is bright enough. He would have seen enough of his people that he grew up, doing bodybuilding, lifting with, die very early. And he's bright enough that he did some lifestyle changes and became plant-based. And he's healthier now than he had been before. Bill Clinton had a minor heart attack, and then he hired the people, basically the best experts in the world. I'll talk about his study in a bit. And then he changed to a plant-based diet, and he's now healthier than he was 20 years ago. So it doesn't matter what political party, or Republican or Democrat, but these people are also bright enough that they looked at that and said, I'm going to bring in the experts in the country. And they went on these diets, and they're healthier than they've been before. Again, if you're a pro football player and that depends upon it, but for health reasons, for long-term life expectancy, it's not really good to be bulked up. Now, again, it's good to do some for strength and muscle mass and stuff, but think about the fact that your blood pressure goes up. Multiple cases of like wrestling coaches and weightlifting coaches in their 40s, early 50s, felt like fire plugs. Stroke out at meetings. I know of two people personally that did that in their 50s. Thought they were in great health, but it's a long-term lifestyle. Does that answer the question?
Yes.
Okay. Talk about problems with lipid levels. We're finding out more and more now. This is a little bit outdated slide, where now sort of the latest data shows it's really not cardiovascular disease, not necessarily correlated with HDL levels. It's the LDL levels that we look at. They used to be the good and the bad stuff. The latest science is no, it's really about what the LDL level is. And that I'm not going to go into a whole bunch of this stuff. It takes a long time to understand this data. We are now in the last 20 years only finding out about this because now we have electronic medical records. When I went to med school, mid last century, we would do studies and you'd be like, you got 200 people in the study. Now with digital records, we can get 200,000. So we get a much better we start looking at the stuff. And now really we look at cholesterol levels. A whole other thing we're talking about cholesterol levels. But really important, what happens here is the endothelial wall gets inflamed, and we don't know what causes the inflammation. There is something in animal products that causes the walls to be inflamed. And then part of the cholesterol adheres to it, and you get the cholesterol atherosclerotic plaques. Why do I say, in my own personal opinion, cholesterol may not be the main player, is because cholesterol is only in animal products. If you only eat plants, you will still develop cholesterol. We produce our own cholesterol in our bodies, and that goes on to be estrogens and androgens. It's very important we have that. But if you're not eating animal products, we will still have cholesterol in our body, but that cholesterol does not adhere to the artery wall. What does that mean? It's not the cholesterol that's the main player. The player is something that causes inflammation in the artery walls. And I'll show you some slides later that show when you stop inflaming the artery walls, you can heal back up and open up these arteries. Next. Metabolic syndrome as a disorder of energy utilization storage, abdominal obesity, hypertension, insulin resistance. Question, does sugar cause diabetes? Sugar does not cause diabetes. The cause of diabetes is insulin resistance. If you have a diet where you have just sugar, good, not too much sugar, we don't gain weight, but just sugar from that, you can actually reverse diabetes just eating sugar, because sugar itself does not inflame the artery walls. What sugar does is when you're insulin resistant, the glucose, the sugar cannot get into the cell wall, so it's then in the blood. So when you treat diabetes, you're not treating the cause, you're treating the symptoms, because you're treating the symptoms, which are elevated blood glucose and everything else that goes along with it. What you really want to treat is what causes the insulin resistance, which is inflammation of the pancreatic cells and fatty disease. Correlation with that. So if you're pre-diabetic and you're taking metformin and you're eating the same food, you will develop insulin resistant diabetes because you're treating the symptoms and not the cause. Does that make sense? And this is a fallacy that most people go through. Most doctors, again, will say, oh, here, take this metformin, eat a little less, don't take your sugar, don't get sugar and stuff is not causing it. It's being caused by something that causes the insulin resistance. Make sense? These are perceptual changes that most doctors don't think about because they're so used to, come in, let's give them medicine, let's give the stuff for hypertension. Oh, by the way, lose some weight. Doesn't work. You have to have people understand why we're taking action. Next slide. Metabolic syndrome. This is an interesting thing. This comes from some occupational stuff because in the occupational world, not only do we worry about decreased productivity for people that are sick at work, but the employer pays the healthcare. So there's a double incentive for companies to really have healthy people. So this is a study that's looking at metabolic syndrome and activity. It's sufficient activity is moderate exercise for 30 minutes a day for 5 days. So this is looked at their healthcare costs from a company. This is somebody who's metabolic syndrome, inadequate activity. This is metabolic syndrome with activity. And this is no metabolic syndrome without activity. So you can see right here, if somebody has metabolic syndrome and is active, it's about the same cost as somebody that doesn't have metabolic syndrome that isn't active. And then if you have no metabolic syndrome and you're active, the healthcare costs are about $2,000 less per year for your employee. And that sort of starts adding up. When you talk to companies, they understand when you start talking money, stuff like that. Next slide. Diabetes, the faces of diabetes. Type 1, usually used to be called juvenile because it was an autoimmune response to it. Now there's so many obese kids, we don't really call it juvenile diabetes anymore. And this is typical for type 2 diabetes. Next, cardiovascular disease. And I'll get into that in a bit, but risk of dying with cardiovascular is third if you stop smoking. Talking about smoking, smoking cigarettes, 4 times more people that smoke cigarettes die of heart attacks than die of lung cancer. 4 times more. The reason you don't hear about it is because everybody's afraid of cancer, obviously, but pretty much everybody that has lung cancer smokes. Maybe a couple percent don't, but not everybody that has heart attack. Not everybody that has heart attacks or have high cholesterol or other stuff. So not everybody that has heart attacks smokes because so many people die of heart attacks. It gets lost. But the reality is 4 times more smokers die of heart attacks related to smoking than die of cancer. That makes sense? So just by stopping smoking, you significantly decrease your risk of dying of heart attacks. Next, heart failure. Again, exercise. You can actually reverse heart failure with a lot of different stuff. It's talking just about exercise. Next. So 4 lifestyle changes that affect mortality risk in cardiovascular patients. First one, dietary changes. I'll spend time on that. Smoking cessation, I'll go into a little bit of that. Increased physical activity and moderate alcohol use. Next. So increased physical activity reduces cardiovascular mortality. Multiple studies have shown like a 24% reduction if you do moderate. What's moderate activity? Moderate activity is moderate exercise, fast walking for 30 minutes times 5, 30 minutes a day for 5 days. And some big studies came out in the last couple of years said, if you go up to the maximum benefit is 1 hour, 5 times a day, 5 days a week. If you go over 1 hour or 5 hours a week, there's no added benefit to it. And why is that? Well, let's say if you're biking 20 miles a week, someone bikes 20 miles a week, and then they go up to biking 100 miles a week, you actually have a bigger risk of dying. Why is that? More likely to get hit and killed by a car. Okay. I mean, you have to look at this type of stuff. And the same way, the more you run, unless you're running on a treadmill, the more you run, if you're doing your stuff, there are lots of studies that show ultramarathoners have a less life expectancy because there's so much stress on your heart. We're not talking about doing that. We're talking about moderate exercise, fast walking, half an hour a day, 5 days a week, as significant changes. And the greatest benefit are those people that are least active. And I will get up here. Every 2 hours I get up and walk around. And I go walk the hallways and stuff because I need to get. And the benefits are with relatively low levels. When I was in Minnesota, which has a really progressive healthcare system, at Mall of America, when it was 20 degrees below, they would actually have bus loads from some of the, what's the politically correct term for rest homes or whatever. Living, yeah. And so they could walk, and they would just walk around the mall. And a lot of malls across the country are now doing that because they look at that benefit. Remember, I showed you the thing about metabolic syndrome and exercise, and it's really important. Next, dietary changes related, and this is the big thing. Multiple studies, and this is average of multiple studies, show a 44% decrease in cardiovascular mortality. It's actually greater when you go into a whole plant-based diet. So this is what I call the non-proof. And this is a study done in 1989, the Diet and Reinfarction Trial. And they had about 2,000 men. Unfortunately, a lot of the studies were done in men. 2,000 men who survived a heart attack. So they actually had a heart attack. So if there were people that already had cardiovascular disease, they survived a heart attack and they given advice or no advice. And the advice was to reduce fat, increase fish, and increase fiber. They just told them to do that. The control group, they didn't tell them. And guess what? There was no difference. That's a zero. I'm looking at no difference means there's zero. There's no difference between the exposed and control group. So I say this is a non-proof. Just telling somebody to reduce your fat, increase fish, and increase fiber has no effect during a couple of years in the study. Next. So this is the classic study. This is by Dean Ornish. And I remember hearing about some of Ornish's stuff. I remember mid-80s, he'd had some people that had heart attacks. They survived, went on his diet, and a couple years later, we're actually running marathons. I said, how did that happen? Well, it can't. So this is the study, the lifestyle heart study. There's 48 patients already with moderate or severe coronary artery disease, followed them for 5 years, randomized, and a vegetarian diet, which at that time probably about a vegan. Vegetarian diet with 10% fat is pretty much going to be close to being a vegan or plant-based diet. Control diet for personal physician. So the control people still had their physician say, lose weight, eat healthy, do this and that. The other group said, listen, you're going to eat plants with no more than 10% calorie, which means probably no added oil. So they assessed heart attacks, angioplasty, bypass and stuff. And so on the vegetarian diet, they had 0.89 events per patient over 5 years. And for the control diet, 2.25 events. So basically 2.5 times less if you follow this diet. And this is pretty significant for somebody. If you had a heart attack and you can follow this, and 5 years later, you're going to be 2.5 times less likely. Does that make sense to you? So they looked at that. Next slide. So here's starting in 1998. This is another thing, angina. You can take your pick now. You want to say that, which is chest pains with exercise because you're not, arteries are narrowed enough. You can't get enough blood there. Experimental group patients, this is the same thing that Ornish did, had a 91% reduction in frequency of angina after 1 year. And what that means is the arteries opened up. They actually opened up. The control group patients were asked to follow the advice of their personal physician regarding lifestyle change. Just telling somebody to do it, not going to happen. You've got to follow up next. So this is 1998. This is another Ornish project. This is a lifestyle demonstration project. Over 300 patients eligible for revascularization, meaning they already had vascular disease. 3-year follow-up, non-randomized. 194 vegetarian diet with 10% fat calorie, 139 control diet per the physician advice. And they looked at cardiac events, which would be angioplasty, bypass grafting, and vegan diet, the vegetarian diet had twice as many angioplasties in the people in the control diet, and almost 3 times more coronary artery bypass. So it's 2 and almost 3. Next. So now we're looking at, any of you heard the Mediterranean diet? Okay, so this has come out, and basically that's dietary patterns of Greece, southern Italy, olive oils, legumes, unrefined cereals, fruits, lots of fish consumption, moderate dairy, moderate wine, and low meat. So they looked at that. We've heard about it. So these studies were published. Next. It was a Leon diet heart study in 1999, 420 patients. Again, they'd survived an MI. They've already had this. And the reason you do something that already has problems is because you can follow them 5 years. If you do something that with a group of population that does not have problems, you may have to wait 20 or 30 years to get the data back. And this is how we do these studies initially. We take people that already we know have disease and we follow them to see what make the disease better or worse. So we had 200 people on a Mediterranean diet, 200 control diets, personal physician, and looking at that composite outcome of deaths, heart attacks and deaths, 1.24 per 100 in the Mediterranean, 4 in the control. So this is a factor. They decrease the risk of heart attacks and events by a factor of 3.5. Remember that, 3.5. Next. The courage. So 2007, this is a study, over 2,000 patients already had myocardial significant. They followed for almost 5 years, and they broke them up into 2 groups. One they call optimal medical therapy, means diet, exercise, and recommended practice. Okay, and the other is optimum medical therapy plus interventions, which is putting a balloon in or opening them up. So we had the same thing. What your doctor told you your diet should be, and then diet should be with intervention. What they find out, there's really after 5 years, no difference. There was no difference in that. And what it meant is unless you make dietary changes, having a stent put in or angioplasty where a balloon blows it up, after 5 years, unless you radically change your diet, there's going to be no change. So there was no change in the diet. The balloon or the stent 5 years later made no difference. That makes sense to you? You follow that? So there's no significant difference cardiovascular if you have stents or angioplasty and do not change your diet. And as a commercial driver examiner, if somebody has a stent put in, we are required after I think year 5 to have another a treadmill done, because so many of those are going to have closing off if they stay in the same diet. Next. So this gets even more better proof. This is a Capagoda stuff in 2006, 134 patients, again, confirmed coronary heart disease, followed for 2 years, 77 followed vegetarian diet, 10% fat, 57 non-adherence. So they had people that were not following this. So of these people that already had confirmed and had lived through a coronary problem, that cardiac events, cardiac death, MR, or stroke, after 2 years, only 1.5 on the vegetarian diet percent had it, 18% of the control groups in a 2-year period. That's a risk, that's a difference of 12 times. People that follow the diets were 12 times less likely to have that. This is when it starts really clicking in. You see, we're at this time about 10 years ago when people were really saying, oh, there are some peer-reviewed controlled studies. Next slide. So this is an American Journal of Cardiology. Significant improvements in angina were found during the 12-week period. Within 3 months, 74% of the people with angina had no more angina, which meant their arteries and their hearts were opening up and their heart was getting enough blood. An additional 9% moved from limiting to mild. So over 80% of people within 3 months on a diet no longer had significant chest pain or angina. Next slide. And here are some proof. This is somebody that has, you can see where this, you think about having a plaque there that lowers down and you have stuff, you're not getting much blood flow through there. So it may be 1/2 or 1/3, which is significantly less flow there. But look what happened. This is what happens after you go on a plant-based diet. It opened up. Do you see the difference there? Next slide. There's another one, small indentation you can right here. That opens up. And the next one is the really most important one. This is a 2.5-year study, if I recall. This is actually a doctor that survived a heart attack. And this is what you can sort of see how close that is. Survived, went on a plant-based diet. 2.5 years later, do you see how much it opened up? See anything else on this one that's different? Vascular. Look at how much it opened up all the other small arteries. So the heart is getting not only bigger, that you see how much more it's opened this up? Because if you have these plaques over the small arteries, they come open up, you can get the stuff. There's also now enough data to show that people that have cardiovascular disease in their abdominal aorta, they may block off the abdominal arteries that go to your low back, and they cannot heal up. And that may be a huge contributing factor to why people have low back pain that's chronic, because in their aortic artery, there's enough plaque that there's not getting an adequate amount of blood to your discs and your back. Does that make sense? This is now, in the last 5 years, they're really looking at that and saying that's something. Same way with Alzheimer's. If you narrow it down, you don't get enough blood, and in your heart, you're not symptomatic until you get less than 40% closure. That's a whole lot. Probably Alzheimer's now, as much as 80% of Alzheimer's are related to cardiovascular disease, narrowing the arteries. And it's hugely 80% correlation with what you eat now for Alzheimer's. And the next studies will come out that Dean Ornish will do. He's been doing a 10-year project on Alzheimer's and cardiovascular, coronary artery disease and vascular disease. Next slide. The proof. This is a really interesting. This is 2014. This is by Esselstyn, who is a physician. He's one of the classic person in this group. Almost 200 patients with coronary artery disease, 3 years, 177 on a vegan diet. Again, now they're saying vegan is switched now to vegan diet. 10% fat calories, no added oil. Oil has a lot of calories. 21 non-adherent. So these people were in the group. 21 decided not to follow the diet. Followed them for 3.7 years. Cardiac events of the vegan group, only 1 out of 177 of people that already had heart attacks had an event. Of the non-adherents, 13 of the 21 had an event. That's 62% of the people that did not follow this dietary regimen versus 6%, only 1 out of 177. And I just read an update to his book. Most of these people are still alive. That continued to follow. This is a factor, 0.6% to 62%, 103 times. 100 times less chance of having recurrence of a heart attack if you change to a plant-based diet. Remember what it was for the Mediterranean diet? 2.5. Okay. Now, imagine if you already have a heart attack and you switch to this diet and you decrease your risk. Imagine what happens if you make this lifestyle change before you have a heart attack. And this is confirmed in studies. There is no statistically significant heart attacks in people that eat a plant-based diet. Statistically significant is 1 out of 20 or 95. And that's when I looked at the data. That's when I switched. It took me 4 years to switch over from a whole plant-based thing to something to where I'm now. It took me a long time, really, really hard. I grew up in Kansas City, in Texas. I can drive blindfolded to the barbecue places. You know, I can do that. But 2 years ago, my best friend in junior high, my med school roommate at Kansas Medical School, went on to become an orthopedic surgeon, chairman of the residency program in a prestigious program in Kansas City. Big guy, used to wrestle, big, overweight but not obese, died of a heart attack, gone. Boom, no warning. His obituary said he loved the New Orleans cooking of Paul Prudhomme, which is lard and butter and brew and stuff. I feel guilty because I saw him 3 years ago at a high school reunion. I was just getting into this. I didn't talk to him about stuff. Probably would have just brushed it off, but gone at 63 years old. And that's when I started looking at this. He was one of the people that had no prior event, played tennis 3 times a week, inflammation of the arteries, gone. Okay, so this is what I want you to think about. I looked at this, and I'm even having a problem because I've gone plant-based, but I'm now only dealing with some of the oil stuff. But I'll go to next slide. Multifactorial cholesterol only in animal products produced in our bodies. I talked about this being endogenous. Inflammation, inflammatory response to animal products. We don't know the exact cause. We thought it was to animal protein, but it may be to endotoxins produced by the bacteria in the animal products. Animal protein, we don't know, but we do know something in animal products causes inflammation in your artery walls, arteries in your brains, in your heart, in your pancreas, in your kidneys. Next. Although, and this is letter to them, although diet and lifestyle modification should be a part of disease management for patients with cardiovascular disease and diabetes, many patients may not be able to comply with the substantial dietary changes required to achieve a vegan diet. And that's someone just saying, don't do it. Well, does it work? We know that the rates of smoking have gone down. That's a public health thing, but there are a lot of reasons. Lots of companies make billions of dollars selling a lot of different food products that are not really healthy for you. Next slide. Smoking cessation, 36% reduction. I'm not going to go over this a whole bunch, but increases life. If you stop smoking, your life goes up. You're going to live longer as a population. We know that. Risk declines once you stop smoking. As it relates to cardiovascular disease, the risk is pretty much gone in about a year. Next slide. 20 minutes, your heart stops to a normal level. 2 to 3 weeks, risk of a heart attack by a year. Not much. And later studies have shown now that if you stop smoking within a year and a half, you have no increased risk for having heart attacks from your smoking. You may have increased risk of lung cancer or something, but from the heart attacks. So this is something, remember I said 4 times more people die of heart attacks related to smoking. So the people that die related to smoking are going to die in their 40s and 50s. It may not be till their 60s or 70s, so they have lung cancer. Next slide. This is just a life expectancy. This is a group of doctors starting in up to 1930. And what this shows is this is death rates. And if they don't smoke at age 70, 80, starting at age 50, you get 10 extra years of your life. Same way over here, smoking stopped at age 35. If you stop smoking at age 35, before you've done more damage, once you get to age 60 and 70, you get another 10 years. Stop smoking is right here. Doesn't affect that. You might get another 9 years. So this is why we say, let's stop smoking no matter what, particularly before you're 35. Next slide. Reducing exercise, alcohol use, 20% reduction. Lots of studies done. They may be biased, but I'll go over this. Moderate alcohol use, 1 drink a day for women, and men over 65, 2 drinks a day for men under 1 for, and that's because in general, men weigh a little more than women do. 1 drink. You've heard all of this stuff. This is how I rationalize my 1 beer a day. And thank God beer and wine are plant-based, but that's a whole other discussion. Now, we look at this, lots of studies show populations that drink a small amount of alcohol live longer than populations that don't. Now, this is contrasted with recent studies in the last 5 years that show alcohol has increased risk of cancer. As a population, however, the increased risk of cancer is probably less than the decreased risk of having coronary vascular. So as a whole, it still washes out longer life survival. But you're going to hear more and more about the fact that people are saying there's no safe level for alcohol. I'm not intuitively going to trust that for a while longer until I see more studies, because I really like having a beer periodically, and I'm not yet ready to give that up. You do make some choices, and I may get to that point sometime, but just to let you know, there are studies that say, and maybe the life expectancy is people that have small chronic use have other healthy lifestyles involved. Because the more you drink, you're probably going to be bigger. The more you drink, the more likely to get in a car wreck and shot and stabbed and all this, a whole bunch of stuff. So it may be selecting. It may not just be the alcohol. Theories where we're stimulating the liver enzymes, we don't know. Next slide. This is interesting. After 26 years of continuous medical practice in East Africa, a colleague, and this is from 1956, a colleague and I recorded the first case of coronary heart disease in the 15 million inhabitants of those countries. The patient was an obese East African judge consuming a partially westernized diet. This is back in the 1950s. This doctor had practiced for years, had not seen a heart attack or cardiovascular disease in millions of patients, and saw it in 1. Next. So this is a couple years old. African Americans cardiovascular disease. Up to 40% of African Americans die of cardiovascular disease or heart attacks. It's maybe around 30-35% for whites, but this is a huge deal. For women, the number one cause of Black women dying is heart attacks. And the prior slide, it's not genetic because they came from Africa. It's because of the diet, the modern diet. And I brought a book here. This is by Eric Adams, who's now the mayor of New York City. He'd been a councilman, didn't care about his diet, almost went blind, and then found out he had diabetes. So I switched to a plant-based diet. And he's written that it's fabulous because it goes into stuff. I cannot talk a lot about African-American diet and history without but he talks about it, and it's just really fascinating. But there is a huge outbreak for that. There's a huge epidemic of colon cancer in young Black men. Black Panther, anyone know what his name was? Yeah. I just blanked on, Chadwick Boseman, 38 years old, dies of colon cancer. Well, he's pumping up, he's eating meat and other processed food. It's not the fact, it's not a genetic thing, it's a dietary thing. Next slide. Lifestyle medicine practice patterns. As doctors, less than half of us advise people to stop smoking. Only 25% smokers offered assistance, a little higher than the military. 1/3 have ever gotten advice to increase activity. 1/3 have hypertension advised. Only 1/3 have increased activity. The 2/3 may get some benefit from that. Only 1/4 received advice on diet and exercise. And one that had peripheral artery disease down in your legs and stuff, basically had BMI checked or talked about it. Osteoarthritis, again, helps if you exercise and move. And elderly people were not counseled to exercise and move. Really important. And only one out of 10 women over 75 were advised to exercise and move more. No wonder your joints get stiff and you have problems and stuff. 2/5 of obese advised to lose weight at regular exams. Again, doesn't help if you just say lose weight. You have to have light bulb moments go off. Next slide. Lifestyle medicine competence. It's a patient-centered approach. Interventions tailored to the patient, unique medical, psychological, and social cultural situation, change-oriented to chronic care perspective, treatment plans focused on the entire risk factor profile. You don't do isolate stuff. Multidisciplinary teams, community outreach, and again, we're going to be focusing on preventing cause, not treating the symptoms. Next. Lifestyle changes in medical therapy should be the mainstay for most patients with stable coronary heart disease, focusing on eliminating all unhealthy behaviors. That's the medical therapy because it comes from a big group. There's a lot of other interesting stuff in that. And because of the cardiovascular stuff, the exercise, the biggest one is diet, next is exercise. And I spent a lot of time on the diet because it's something that we have the studies that show remarkable changes. Again, people that follow a real healthy diet have no statistically significant cardiovascular disease. Next, and no statistically significant colon cancer or prostate cancer, and probably a 50% decreased risk of breast cancer in women. Pretty staggering. Okay, lifestyle, it's the first American College of Lifestyle Medicine. It's the first national specialist society for providers who utilize lifestyle interventions. I've been to a couple of the conferences, and you've been certified, correct?
Yes.
So there's a certification process yet. They're working on actually eventually getting a residency training program. It's going to take a while, but they do have a certification. I will do that eventually. Next slide. And lifestyle changes ahead. I've got a couple minutes. Did this make sense to you? Questions on anything? Yeah. I personally didn't have much withdrawal on it. But the biggest thing you have to do is if you're on some medicines already, if you're on hypertensive medicine or diabetic medicine, you will need to work with your provider because within 2 weeks, there's such a staggering decrease in these levels that you need to have somebody medically follow with that. For me, I change my diet. It takes a couple days where you might get used to it. I'm to the point now, I have changed my diet so much. I can't even eat grapes because they're too sweet for me. I don't eat a lot of sugar, but it still tastes good the few times I have it. But I mean, I last week went to a friend's house and they had a vegan cookie and vegan ice cream on it. And I said, I'm going to do it. I'm at a friend's house. The hardest part is the social part. I ate it. And a half an hour later, I was almost nauseated because my gut bacteria was not used to using that. But it's just, you can find, it's good to do it with somebody else, a spouse or somebody, or a group together to do it. But for me, for volume, I mean, you can eat a candy bar that has 400 calories in it. And if you have vegetables in a wok, I can't eat that much because 400 calories is too much. It's just the stomach won't work out. So next, I'll stick around afterwards if there is specific questions. You have take over on.
Oh, yeah, I accidentally hit the slide, sorry. But did just want to say that is an avenue to get plugged into other healthcare professionals that are interested in practicing this or learning more. And these are the ways to reach us. We can make sure the slides get sent out at a later time for those that are interested. That QR code there gets you an opportunity to just complete a quick digital survey that will get you linked to the distribution email listing so you get updates. And then American College of Lifestyle Medicine has a ton of free resources for healthcare professionals. You can check that out for those that are interested. Interesting question, ma'am, that you had, because we do have another event coming up about ultra processed foods, and they're actually looking at being classified as addictive as a substance use disorder type situation, because a lot of those same, your brain and the highly processed foods has a lot of those same scenarios. I've personally had patients explain to me in lots of lectures talking about everybody's different, obviously, with how they respond to switching to a diet. But within a week or 2 weeks, just as Dr. O'Neill mentioned, super fast that your taste buds change. And if you can get through it within a week or two, people have tested that fact by going back to what they used to eat, and they feel terrible typically after that 1 to 2
It
weeks.
took me 3 years to make this change.
Oh, absolutely.
I
For some people, it can be slower.
Meat and chicken and some other stuff. I find it took 3 years, and I'm pretty focused. So be pretty easy on yourself.
Agreed.
Every person I know that died of a heart attack, and every time I read about somebody that died that was younger than I was, I got encouraged to look at this. And I'm only now finishing this journey because I'm now dealing with this 10% added fat. It took me 5 years to get to that point. And, I'm even now, I need another, I don't have another hole here. I need to do that. Because if you're eating whole plants, you cannot eat enough calories to, I don't even count calories anymore. They don't have to. But what I want this to do is at least have this lecture or something like it be a starting point for you to start to think about changing your life and living longer and better and healthy and not having cardiovascular. You can talk about cancer, you can talk about arthritis, all the other things. There are lectures just on that. I focus is just on the cardiovascular because that's what kills most Americans. And you get your biggest bang for your buck on the cardiovasculars. And we will see stuff in the next 2 years about Alzheimer's and how it can probably even be, in some cases, possible as you open up the arteries. Yeah. Happy to stick around. I hope you learned something. And thank you very much. I want you to live longer and better.